Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai in New York City. And today I'm speaking to you from San Diego, where I'm at the Pediatric Interventional Catheterization Symposium, and I'm having a wonderful time on my last day at the meeting. I hope everybody enjoyed last week's episode on the topic of representation in pediatric cardiology. We spoke with Dr. Ogie Cox, who's a third-year fellow in cardiology at the University of Michigan. And for those of you interested in the concept of enhanced diversity amongst the workforce in pediatric cardiology, I'd recommend you take a listen to last week's episode. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week, we move on to the world of interventional cardiology, which seemed appropriate given that I'm at an interventional cardiology meeting. The title of the work we'll be reviewing is Off-Label Uses of the Amplatzer Piccolo Occluder in Children with Congenital and Acquired Heart Diseases. The first author of this work is Ashley Malloy, and the senior author, Shyam Sathanandam. And this work comes to us from the Department of Pediatrics, Division of Cardiology at the University of Tennessee Health Science Center, LeBonheur Children's Hospital in Memphis, Tennessee. When we're done reviewing this paper, I'm excited to have Shyam Sathanandam speak with us about it. Therefore, let's move on to this paper and then a conversation with its senior author. This week's work starts with a number of comments about how, because of the extreme variability of disease and problems seen in congenital heart patients, it's common and perhaps even a tradition within the field of pediatric interventional cardiology to use devices in an off-label manner to achieve various therapeutic goals in the cardiac cath lab. The authors then remind us about the Piccolo device, explaining that it was recently approved for closure of PDAs in infants greater than 700 grams. They explain the nitinol mesh design and review how it comes in 9 different sizes, with diameters of 3, 4, and 5 millimeters in the waist of the device, and lengths of 2, 4, and 6 millimeters. And they explain how in the 3 millimeter device, the outer discs are 1 millimeter larger, or 4 millimeters. In the 4 millimeter device, the outer discs are 1.25 millimeters larger, and therefore 5.25 millimeters. And in the largest 5 millimeter device, the outer discs are 1.5 millimeters larger than the waist, or 6.5 millimeters in diameter. They mention also the device discs and suggest that this is an advantage in comparison to some other devices, as embolization could be less common because the discs may allow for better anchoring. They also remind that unlike other devices, this device can be delivered through a very small 4 French catheter and does not require a microcatheter. With this as a background, the authors explain that the goal of this work was to describe its use in multiple uses of off-label use to treat small-diameter congenital or acquired heart defects in children. This was a retrospective review of patients who had a catheterization from January 2022 till June of 2023, so roughly 1.5 years, in which a Piccolo was used for something other than a PDA. And on to the results. In all, there were 9 patients in this work who had a device placed in a defect other than a PDA. And there's a very nice table, Table 1, that summarizes nicely the interventions, patients, and outcomes. Allow me to summarize the indications and cases, and mention that those who are interested for the granular details should certainly take a look at the paper. Basically, the most common indication for use of this device was for closure of small coronary fistulae. There were 4 in this series, with the narrowest segment ranging between 2.8 and as large as 5.8 millimeters. Importantly, the 5 millimeter device, or the largest of the Piccolo devices, was used in all of these cases. Second most commonly closed were small residual VSDs in 2 patients, where the narrowest diameter was 3.4 millimeters and 3.9 millimeters, and both patients received 5 millimeter devices. The remaining cases were a patient with truncus arteriosus who had an interrupted aortic arch type B and aortic root replacement in which there was a pseudoaneurysm in the left ventricular outflow tract that was about 2 millimeters in diameter and was closed with a 5 millimeter device, as well as a patient with a perimembranous VSD who needed a pacemaker and had an acquired Gerbaud defect measuring 3.4 millimeters, and this was closed with a 4 millimeter device. And finally, a fascinating case in which the team had placed a fenestrated ASD patch in a patient in which they were hoping that the LV would grow for eventual 2-ventricle palliation. As the child was growing, the team felt that the ASD that had been surgically placed should be made smaller, and so they placed a 10 millimeter Amplatzer ASD device at 20 months of age, in which they had placed 2 3 millimeter fenestrations. 1.5 years later, they wished to close one of the small intentional ASDs, and they were able to pass a 4 French torque view delivery catheter through the fenestration and close it with a 5mm Piccolo. And there are some lovely images of this intervention in the paper. The authors also reviewed the LV outflow tract pseudoaneurysm, and the images are lovely, and they show how they could place the Piccolo into the pseudoaneurysm with the relatively small Piccolo 6.5mm proximal disc in the LV outflow tract, and the transesophageal echo confirmed that the device was not affecting aortic valve leaflets, and they posit that though there may be other devices that might have worked to do this, this device with its relatively small discs was ideal, avoiding injury or problems in general with the aortic valve. In regards to VSD closures, the authors comment on the small size of the patients and the large and bulky Amplatzer muscular VSD occluder delivery system and device, and note how the 4 French torque view delivery catheter easily could be positioned without much hemodynamic disturbance. In both ventricular septal defects, the authors did the typical rail system, whereby the VSD was crossed retrograde, wire snared in the pulmonary artery, and then externalized, and the 4 French delivery catheter was then advanced to the defect along this wire. The Gerbaud defect was similarly closed in this manner, and in all 3 patients with VSDs, the patients clinically are reported to have improved. There are details of the coronary fistulae that were largely iatrogenic in transplant patients from biopsies, and again, the authors used a rail, whereby they crossed the coronary and fistula, retrograde, exteriorized the wire, and then delivered devices successfully transvenously over the wire. There were no complications encountered. In their discussion, the authors explained that the uses described herein were all off-label, but suggest that the cases they describe might be, to use the author's words, instructions on the use of this in an unapproved manner. They explain how in some of these interventions there was no alternative, and point to the fenestrated ASD case, which they believe likely would have required surgery, or the LV outflow pseudoaneurysm, where other devices might have impacted the aortic valve in a suboptimal manner. They explain that the fistulae seen in the coronaries here were from biopsies, and suggest that without these interventions, repeat transplantation might have been needed due to progressive coronary steal. They mention how the larger retention discs of this device give the operator a bit more comfort, as it has the chance for the device delivery being more secure, avoiding embolization. They also comment on how the small delivery system allows delivery of devices antegrade or retrograde. The authors mention the absence of long-term follow-up in this series and the absence of acute complications, and suggest that longer-term follow-up will be helpful in determining the safety and efficacy of this approach. And so they conclude, the Amplatzer Piccolo occluder can be used to successfully occlude small defects of many varieties in children and infants. The 4 French delivery system allows the device to be used in small patients that cannot tolerate the large delivery systems of other devices. Well, I did not intend this week to suggest that the work we're reviewing is high science. However, I think sometimes new ideas get published like this in the old case series manner, and this one I felt was interesting because it was describing the use of a novel PDA plug in unapproved ways. And who better to be doing this than its senior author, Dr. Sathanandam, the master of the Piccolo. I'll be honest in saying that some of these, particularly 1 or 2 of the residual VSDs, or the very tiny coronary fistulae, did not scream out to me as being serious clinical problems, and I'm not sure that I believe that the presence of coronary fistula, even with some mild increasing of LV size from shunting, would be considered a rationale for retransplantation. But there's admittedly variability in clinical practice, and the reality is that this device allows for interventions that might not have been feasible in the past, and so perhaps I may change my mind as more cases of these types are attempted and accomplished in a safe manner. In the interest of time, I think we should move forward to our conversation with the work's senior author. Shyam Sathanandam is professor of pediatrics at the University of Tennessee, and he is the medical director of the Cardiac Catheterization Laboratory at LeBonheur Children's Hospital in Memphis, Tennessee. He is a graduate of the Stanley Medical College in India, completed his residency in pediatrics at SUNY Downstate in Brooklyn, and completed his pediatric cardiology training at Advocate Christ Medical Center, followed by pediatric interventional cardiology fellowship at the Children's Hospital of Philadelphia. He is the author of many publications and is the foremost authority worldwide on the Piccolo device, and has led the world on its adoption and taught us all how to safely perform these procedures. It is a delight and an honor to have him join us this week to discuss this week's work. Welcome, Shyam, to the podcast. I'm here now with Dr. Shyam Sathanandam. Shyam, thanks so much for joining us this week on Pediheart.
Thank you so much for the kind invitation. It's a pleasure to be in this podcast, and I'm excited to chat with you.
Thank you. Excited to have you. A lot of buzz this week on the internet about you joining, so thank you for doing that for me. Shyam, I'm wondering if you could share with the audience what you believe to be the advantages of the Piccolo device that led you and your team to use the device for some interventions that are, shall we say, unapproved that you describe. Was it just the presence of retention discs in this device or something more?
Oh, thank you for that question. So before I start, I must say that like most things that we do, our experiences are built upon the ingenuity, the inventiveness and innovations of others who came before us.
Yes.
So when I see others kind of come up with innovative solutions for difficult lesions, that's kind of what motivates me to kind of think outside the box. So as you know, the Abbott Amplatzer Piccolo occluder, it's actually a very versatile device. It can be used just as a regular vascular plug, besides its on-label indication, which is closing PDAs, especially in premature infants. And you are correct. The biggest advantage of this device is it has retention discs. The retention discs really help to anchor the device very well. Compared to other small occlusion devices, such as, let's say, the Medtronic microvascular plugs,
yes,
or even coils, they do not have discs. Therefore, they work by being oversized rather than being anchored. And this has retention discs on either end, so it will anchor on both sides.
Yes.
Like many of the lesions that we use this device for off-label, that was described in this paper, we typically ended up creating an arteriovenous wire rail.
Yes.
And as you know, we create these AV loops for stability. Sometimes just to cross certain lesions with a catheter, such as ventricular septal defects or coronary artery fissulas, we need this AV loop to just stabilize the catheter to introduce them into the lesion.
Yeah.
In which case, when you're occluding these lesions, you need real stable devices. So having a retention disc is probably the best suited devices for these lesions. And I think the Amplatzer Piccolo occluder fits the bill perfectly.
Yeah, and I think for those in the audience who haven't created one of these AV loops, it can take a little while in the lab to do that. It's quite a bit of effort. So the last thing you want to do is do that whole AV loop and then find out that the device you chose is not right, and then you're basically at the starting line all over again and have to redo the wheel, as it were. So I could certainly understand that. How do you size this device when you're closing defects other than PDAs? In some cases, I noticed that the discs of the devices that you chose were really only maybe a millimeter greater in size than the narrowest diameter of the structure that you were closing. How do you know, for example, that the device is going to remain stable in position? Are you tugging on the device to try and kind of indirectly assess the stability? How do you make that determination?
Well, that's a great question. As you know, for off-label uses, it is impossible to come up with an instruction manual for sizing. So we use some simple principles for sizing. And I've used this Piccolo occluder for PDA closures in over 500 patients now. So I have a vast experience with this device, and I'm comfortable knowing what this device can and cannot do. Right.
Yes.
So it comes in three sizes based on the middle disc size of 3, 4, and 5 millimeter. The retention discs are 4, 5.25, and 6.5 millimeters respectively. So pretty much, if you read the paper, we use the largest size device for pretty much every lesion.
Yes.
Which means that the retention disc for these devices was 6.5 millimeter. And we chose to close defects that were at least the narrowest size of the defect was less than 6.5. And which means that the retention disc will hold on and prevent it from migrating or embolizing. So let's say even if we closed a 3 millimeter lesion with a 6.5 disc, we had to be careful about the adjacent structures, not to either compress or occlude the adjacent structure. For example, we had a couple of ventricular septal defects, and even the LV outflow tract pseudoaneurysm.
Yes.
They were pretty close to the aortic valve. So we had to measure on the transesophageal echo if there's enough room for a 6.5 millimeter disc that it does not, one come close to the aortic valve or even like affect the mechanics of the aortic valve. And thankfully, this device is very soft, and it prevented any obstruction of the aortic valve. The only lesion we had concern was the one lesion, which was a Garbodi defect, which was a left ventricle right atrial shunt. We were concerned that even after we created the wire rail, that we didn't know where exactly the conduction system was, and the tricuspid valve, the septal leaflet was very close to the defect. So we chose a slightly smaller device for this defect, which is a 4 millimeter sized device. And otherwise, we just used the larger size Piccolo occluder for all cases.
I see. Yeah, that's what it seemed like. You pretty much used the 5 millimeter device in everybody, with one exception, as you just described. I'm wondering, Shyam, based on your experience, I'm sure even since the time you wrote this paper, I'm going to guess that you've used it off-label even more times. Can you share with the audience what you think, shall we say, off-label might be some of the better indications for this device? It seemed like coronary fistulae was the most common lesion you used, but I'm wondering what your thoughts are on this.
Thanks for that question. Yes, you're correct. We've used it several times now since the paper was written. So the number one indication for us was coronary artery fistula. As you know, sometimes these can be tricky, and this device works great. We used it in several what we call residual ventricular septal defects. They are surgically closed, but then there were some residual shunts which prevented these children from making progress postoperatively. So we use this device for it. We basically use it for small shunt lesions. For example, we used it in one patient where we had converted a hypoplastic left heart syndrome patient into a biventricular repair.
Yes.
As part of the conversion, as you know, we have to septate the heart by closing the atrial septal defect. And this patient wasn't ready for an ASD closure, so we fenestrated an ASD device to close it initially. But then we came back a year later saying we had to close this fenestration.
Yes.
Now, as you know, this can be very tricky. This was actually our very first case, and I wasn't sure how to close this fenestration in a device. So basically, we had to place a device inside a device. So we did some bench testing where we placed the Piccolo occluder into the Amplatzer septal occluder, and it worked fine. And so we carried out that procedure. And so it is good for like closing fenestrations that the surgeon sometimes make, including like Fontan fenestrations. But at least Fontan fenestration, we have other devices. So to summarize for our off-label indication, what I would say is it's good for muscular VSDs, membranous VSDs, fenestrations that the surgeons create, the coronary fistulas. Sometimes, we come across muscular VSDs where there are multiple Swiss cheese type defects.
Yeah.
We typically choose to close the bigger defects and leave the smaller defects alone. So this device may actually help even plug these smaller defects, so we have better occlusion. One could argue that it can be used as a vascular plug for AV fistulas, AV malformations, aortopulmonary collaterals, VV collaterals, but obviously it is an expensive device, so it should not be our first choice. So whenever available, consider other devices. But if you need a retention disc, I think this is a really good device for these lesions.
Thank you for that answer. I think the fact that it goes through a 4 French catheter is clearly a big advantage. And also it seems, which is very soft, and I think also the fact that the device itself is very soft may explain why, shall we say, you get away with using it in some dicey areas like that pseudoaneurysm that was right underneath the aortic valve in that truncus patient you described. One thing I wondered about, Shyam, was how occlusive the device is. It seemed like in your study, everything that you closed with it stayed closed. Do you have any concerns regarding the ability of the device to close arterial connections? It seems obviously pretty effective through your work and that of others in closing PDAs. But are there high flow situations where you would be concerned that not having fabric in the device might be a problem? For example, the Amplatzer VSD device, muscular VSD device, does have fabric in it. ASD device has fabric in it. Do you think are there situations where you're a little uncomfortable because you're worried it won't actually close?
Yeah, you are correct in stating that the Piccolo occluder does not have any fabric inside it. So there's always this concern for residual shunting through the device. However, because there's no fabric, makes the device actually less bulky and allows it to be delivered through a 4 French catheter.
Yes.
Um, you're surprised. It's really incredibly occlusive. For the PDAs, which are high flow lesions, it really works remarkably well.
Yeah.
I'm not an engineer, so I cannot explain exactly. But part of the reason I believe why it is very occlusive is the nitinol fibers are laser cut so precisely and so fine that allows them to kind of the device is woven in such a fashion that it allows it to be completely occlusive. Again, I'm not the engineer, so I can't be
Sure.
totally sure of that, but it is very occlusive. In this series, we did not have any residual shunt through the device. We did have one patient with a very complex coronary fistula, which was an iatrogenic in nature, secondary to myocardial biopsies. That patient did have a residual shunt, but not through the device. It was through other channels which are surrounding the device. So we had to place a second device in that patient in the 6-month follow-up cardiac catheterization. Otherwise, it was very occlusive.
I wonder how your biopsiers enjoyed doing biopsies and avoiding the Piccolo device. I can imagine that pathology report. Well, for those in the audience, it's kind of late on Wednesday evening, before the release of the podcast on Friday, but I'm going to take advantage of Shyam now, and since we have the absolute guru in the world of the Piccolo device, a person who has really demonstrated to the entire world the efficacy and safety of this device. So although it's not related at all to this work, given that we are lucky enough to have you on the podcast, I'm wondering if you might be able to share with the audience any new updates on things that might be coming in the near future with the Piccolo system in the next 1 to 2 years. Are there any aspects of the device that you've been iterating, and is the company going to be changing any of the design, either in the catheter, the device, the sizes? I'm wondering if you could maybe hint to us about what's coming down the pike.
Yeah, thank you for this very important question. I do want to point two new updates. Nothing related to the device per se. One thing I would say is the Amplatzer Piccolo occluder is a remarkable device. For PDA closure in premature infants, it is unrivaled. Mm-hmm. However, many operators still have hesitancy in using this device in premature PDA closure, let alone for off-label indications. But the main reason is not the device itself, it's the delivery catheter. The delivery catheter was not designed for premature infants. The distal tip of the catheter is not specifically designed for the premature infant PDA morphology. Therefore, many in the interventional cardiology community felt that it is time to petition Abbott to modify the delivery catheter for the Piccolo occluder. They listened to us. The engineers and the R&D teams within Abbott have worked with us in developing a catheter that is now soft, that can be used to navigate through the heart of premature infants without causing any less concern for damage to the myocardium or the valve structures. So you'll be able to use the same catheter to cross the duct and close the duct. So you don't have to do a catheter exchange. Now, what also excites me is the catheter tip now has a ductal curve, which is similar to like a Judkins right for the right coronary or the Judkins left for the left coronary. Now we have a catheter which actually has a PDA curve. And I'm hopeful that this catheter will be available to all of us by next summer. So that will be exciting. More interestingly, the catheter will be short. We worked with the engineers in designing the catheter and almost like a delivery system that will work at the bedside in the neonatal ICU. So eventually, I do think this is a procedure that has to be done in the NICU at the bedside without angiography. And I'm convinced in the next 5 years or so, everybody in the interventional cardiology community are going to be traveling from NICU to NICU like surgeons used to doing PDA ligations in multiple hospitals. So that is one update, the new delivery system.
Yes. And let me just interject, Shyam, for those in the audience who aren't aware. When we do a Piccolo closure, we cross the defect presently, typically with a glide catheter, which is a very soft hydrophilic catheter, and then we exchange it for the delivery system, which is soft, but not optimally soft, perhaps. And so anytime we have to go out the PDA and across a couple of valves in the heart of a baby, there's always a chance for hemodynamic instability. So I'm guessing one of the big advantages is that we'd only have to do that once instead of having to do a catheter exchange with a stiff wire, et cetera. So I'm sorry to interrupt you, Shyam, but just for those who weren't as aware of that.
No, thank you. Thanks for clarifying the procedure. The second update I would like to provide is not on Piccolo itself, but the therapy of PDA in premature infants. There are multiple clinical trials that have been conducted over the years. Over 80 prospective randomized controlled trials have been conducted. And the problem is none of these studies actually show benefit for closing PDAs in premature infants. But these studies have flaws. Most studies do not even have an echocardiogram to determine PDA size, let alone shunt volume. So when you bunch small and large PDAs into one study, you don't probably get the right results. And all studies previously have been done using medical therapy typically. We don't have a definitive closure like transcatheter PDA closure. So currently in the USA, there is a randomized trial called the Pivotal trial that is underway. What we are comparing is a transcatheter PDA closure versus responsive management, which is basically just observation. And it is based on a very strict selection criteria. So those who are enrolled have very large hemodynamically significant PDAs based on some strict criteria. And kudos to Carl Bacchus in Nationwide Children's Hospital, who's been leading the way in this. And hopefully this question of whether PDAs need to be closed at all in premature infants could finally be answered. So I'm excited about this as well.
Wow, that's very exciting. Maybe get the definitive answer finally. Well, Shyam, I can't thank you enough. Thank you very much for joining us this week on the podcast. Congratulations to you and your many co-investigators on this paper. And let me thank you on behalf of the entire community for teaching us all how to close PDAs in premature infants, something that was never thought to be feasible even 5 or 10 years ago. So really remarkable accomplishments, and I'm very honored to have you join us this week. So thank you.
Thank you so much for having me on this podcast. It was really good talking to you.
Nice to talk to you as well. Thank you. Well, I think you now see what a terrific guest Dr. Sathanandam is, sharing with us a number of ideas regarding why the Piccolo device is so good for smaller defects, and also offering us some thoughts regarding what lesions might be better served by this particular device in an off-label manner. I hope you are excited by his comments about a new delivery catheter for the Piccolo, and also a new prospective trial of transcatheter PDA closure in the premature infant. Shyam has really been the world's authority on this important device and intervention, and it has been a delight to have him join us this week to discuss his deep knowledge of this device with all of us. To conclude this 311th episode of Pediheart Pediatric Cardiology today, we hear the wonderful French soprano Nathalie Dessay. Ms. Dessay, who was born and raised in Lyon, France, was an opera superstar noted for her wonderful acting abilities and stratospheric voice, able to hit extremely high notes, seemingly without effort. She sang right up until around 2013, when vocal problems derailed her career in only her mid-40s. However, we have many wonderful mementos of her beautiful singing, such as this recording of the fiendishly difficult aria from Mozart's Magic Flute. Thank you very much for joining me for this 311th episode, and thanks once again to Dr. Sathanandam. I hope all have a wonderful week ahead.